channel if you're interested. Okay, so I think our recording has just started, and so I will also start by talking about eating disorders with you all. And do please feel free to put questions in the chat or chime in while I'm reviewing this. I'd love to have a discussion with you all. Because like I said, eating disorders can sometimes feel like niche conditions, but they're really not so different than other kinds of medical and psychiatric illnesses that all of you see every single day. So eating disorders sometimes feel like conditions that grow in the shadows, right? So there's a lot of internal processes that come with eating disorders that can be fueled by isolation and disconnection. And something that's really striking about the eating disorder fields is how substantial illness has gotten in terms of the prevalence and the severity of what we've been seeing in the wake of COVID. And so I'll just show you some data to really articulate how much eating disorders have skyrocketed in the past few years. So this is showing you inpatient admissions at a tertiary care children's hospital in Boston, Massachusetts. So they cared for patients ages 8 to 26. And if you look right there, there's, 10 inpatient admissions, pretty standard across time. But right around the beginning of COVID, you can see that massive spike after COVID restrictions were implemented, really showing that eating disorders were thriving in that stress and isolation for kids, and that those graphs have just continued to grow through the many years since then. Here's another example. This is a 4-year retrospective chart review of all patients in a hospital in Australia. And so this is showing, really the massive rise in the beginning of COVID restrictions were here in March 2020. And you just see the massive increase in inpatient and hospital-based care. It's really a substantial, even a 50% increase. And this is really, seen not just in certain isolated places in the country or internationally. It's really across the board that we're just seeing this massive increase in volume of folks needing high acuity care. And it's not just high acuity, it's really all levels of care. And so this is showing claims data for medical claims across the entire country. And there was a 65% increase nationally for eating disorder claims as a percentage of all medical claim lines. And so really showing this really massive increase in the number of people that are needing to get medical and psychiatric treatment for eating disorders, which is, especially concerning given that we really, as a field, don't have that much to offer people. So there's really a crisis when it comes to care, especially for eating disorders, for a couple of reasons. So even if people can get to a hospital, get into a program, get access to a specialized treatment provider, there are no binding standards of care, right? So there's nothing that is required of eating disorder practitioners, even though there are evidence-based treatments. There's really a shortage of trained clinicians. There's incredibly poor insurance coverage. There are long wait lists, and there are very few academic programs that lead to, access and innovation in treatment for eating disorders, which leaves us in this really tricky position of having massive numbers of people wanting care for eating disorders and having very little specialized care available to provide, which makes me especially grateful for this opportunity to share with you all about eating disorder treatment. And I'm going to address a couple of questions today in our conversation. One is the basics, right? What are eating disorders? What causes eating disorders? What are treatment recommendations from evidence-based treatment for children and adolescents? And what are those same recommendations for adults? And my hope is after this conversation, each of you feel a bit more empowered to feel like, even though eating disorders feel niche and special, that there's something that you can tackle with some knowledge and framework in your own practice. So I'll dive right in and provide an introduction to eating disorder care. And where should we start? Let's think about what eating disorders are from the very basic foundation. So they are psychiatric conditions that frequently affect teenagers and young people, but also children and adults of all ages, also of all genders, all ethnic backgrounds, all cultures, and all body weights. And so sometimes there's a stereotype about eating disorders that they really only affect like skinny, white, affluent girls is the stereotype, and that's really not the case. Common symptoms of eating disorders tend to include behavior changes around food and body. So things like fasting, restricting food intake, binge eating, and purging. I'll explain what those behaviors are. Body dissatisfaction beyond what's, normative in our culture. Low self-esteem, a strong desire to lose weight or an intense fear of weight gain, social isolation, and denial of the severity of the problem, which makes it hard, right, to navigate that initial part of treatment, but doesn't make it impossible to help people become well again. Eating disorders are categorically defined in the DSM. So I will explain the categorical definitions, but really focus in this talk about the behaviors because they can span across categories. So anorexia nervosa is sometimes characterized by a refusal to maintain a minimally normal body weight in the context of restriction. This has the highest mortality rate of any psychiatric condition after opioid use disorder, but that's because of, sad statistics around overdose. Bulimia nervosa is really characterized repeated episodes of binge eating followed by compensatory behaviors. Binge eating disorder is characterized by repeated episodes of binge eating. And ARFID is characterized by, similar restriction as seen in other eating disorders, but this lack of interest or avoidance of food could be more related to sensory characteristics or aversive consequences of eating in comparison to body image concerns. So these are the categories, these are the codes that we have to put into our evaluations and our progress notes. But really, we can see similar looking behaviors across each of these conditions. And so I'll explain the behavioral pieces of it in a little bit more detail. So restrictive eating, one of the hallmarks of eating disorders. What restriction can look like really varies. So dietary restraint describes how tightly food intake is controlled in order to manage weight. For example, the eating disorder examination is one of our tools to evaluate eating disorders, and this is a question that it asks about restrictive eating. Have you been deliberately trying to limit the amount of food you eat to influence your shape or weight, whether or not you succeeded? So let's keep in mind with restrictive eating that the successful application of restraint is not necessary to characterize someone as having high dietary restraint. And restraint can look very different. So another example is, have you tried to follow definite rules about your eating, like a calorie limit, in order to influence your shape or weight, whether or not you succeeded? So again, successfully applying that rule doesn't matter. It's just the existence of the rule, and what that rule can look like can really vary. So it could be a calorie limit or an overall intake amount. It could be restricting particular food groups or particular food categories. So one of the things that we see often is people restricting their carbohydrate intake because of how popular some of those high protein type messages have been in recent years. But it also could be true around, sweet foods, could be around certain categories like dairy. And if those things are in order to influence shape or weight, then that would be considered dietary restraint from like an EDE perspective. People can also engage in restrictive eating from an ARFID perspective, so avoiding particular food types or categories outside of wanting to influence their shape or weight. And that would still be considered something that could be part of a pathology or getting in the way of their everyday life. And restrictive eating is on a continuum, right? And so I'm sure that everyone here in this talk today knows someone or perhaps has been someone that has looked into like dietary restriction based on physician recommendations or wanting to change their shape or weight. And there's ways to do that that, sometimes people do recommend for medical reasons or for other reasons. But this is really looking at restrictive eating that follows definite rules specifically in order to influence shape or weight, not necessarily for health reasons. Like, for instance, folks that need to make dietary changes because of diabetes or high blood pressure or things like that. So that's restrictive eating. I will talk about binge eating next. And so in the DSM, binge eating is defined specifically in binge eating disorder with more nuance, but can be present in any of those categorical eating disorders, so anorexia, bulimia, or binge eating disorder. There can also be binge eating behavior in ARFID, but it's not part of the diagnostic system. This is characterized by a couple of criteria. So eating an unusually large amount of food with an experience of loss of control. And then the binge eating episodes in binge eating disorder are associated with 3 or more of the following: eating faster than usual until you feel uncomfortably full, large amounts of food when not hungry, eating alone because of feeling embarrassed about how much you're eating, feeling disgusted, depressed, or very guilty afterwards, and those are the things. But it's pretty hard to specifically nail this down, right? It's not easy to know what an unusually large amount of food is or what loss of control is. Um, I have been in conversations with eating disorder clinicians where we sit and debate whether an amount of food is unusually large for way too long. And I would say that there is some normative practice for humans engaging in regular balanced eating, where sometimes we eat more pizza than we want to, right? Like one piece of pizza is not a real human serving size. Um, but that wouldn't necessarily be binge eating unless all of those other things were also present, including loss of control and 3 or more of the things on that list. So, for example, an unusually large amount of food is typically something that's defined like 2 dinner-sized portions, right? Whatever that is, but it's also depends on the context, right? And so Thanksgiving is a time when everyone is eating a large amount of food. It's not an unusually large amount compared to other people. And so it wouldn't be something that would meet that criteria unless there's also a really significant loss of control. Um, Loss of control is actually really much more important than the amount of food. That's true in kids, but especially in kids, but also true in adults, that loss of control experience is more related to psychopathology than the amount of food. So let's talk about what is this loss of control. Typically, people describe, different experiences, but some examples could be, it's like you're on the top of the hill and you have a ball and you start rolling it down the hill and you run to catch it, but it's sort of going faster and faster and faster. You're never going to catch it. Or it's kind of like the train's already left the station. There's no way you're going to be able to slow it down. Or like kicking a can down the road and then it's just rolling faster than you could ever go to catch up with it. And people really, if you explain those metaphors, people will readily endorse those experiences around food when they're engaging in binge eating. So that's binge eating. So we've covered restriction, we've covered binge eating. And so now we'll talk about compensatory behaviors, sometimes just called purging, which is less accurate since compensatory behaviors can really be more varied than just vomiting, but it's compensatory behavior broadly. This can be vomiting, laxative use, fasting, over-the-counter pill use, diet pill use, or driven exercise, things like that, or anything that someone believes is going to compensate for food intake or for lack of activity or for in some way to influence people's weight or shape. It can really depend on whether it's compensatory, it can depend on the context, whether it's excessive use and whether there's an intent to counteract a binge or regular eating behaviors. Just to note for everyone, psychoeducation can really be powerful when it comes to compensatory behaviors to encourage patients to engage in more safe behavioral regulations. So, for example, vomiting can be one of the more dangerous eating disorder behaviors because folks put themselves at risk of electrolyte imbalance through regular vomiting. And that electrolyte imbalance can cause cardiac complications or even heart attacks and death. So, when you say that to someone, they're less likely to engage in that behavior. But what makes it even less likely that people engage in vomiting behavior is that it doesn't really compensate in the way that folks hoped that it would. And so when folks consume any amount of food, there's immediate absorption of caloric of the calories consumed, and vomiting doesn't really actually get rid of the amount of food that's consumed, and it isn't really effective. That's also, very true of most over-the-counter and diet pills, which are often not FDA regulated and pretty unsafe. And so providing that education is really important for patients that are engaging in these behaviors. So this is much more detail that the body absorbs 40 to 75% of calories even after vomiting. Also laxatives, right? They don't change anything about the amount of food consumed or absorbed. And actually, folks can get pretty dependent on laxatives, especially those stimulant laxatives, which can cause quite long-term GI complications. And so if you really talk about that with patients, they're much less likely to abuse laxatives. And they really do. They can have long-term physical consequences in ways that are often irreversible. So those are the behaviors. I will talk now about some associated cognitive components in eating disorders, just as some examples of experiences that folks might have. People can be very preoccupied with thoughts of food or body shape and weight. They might show obsessive or compulsive tendencies related to food. They might have ritualistic behaviors at meals, collect recipes or prepare meals for others, or spend a lot of time planning or talking about food intake. People can also have magical beliefs about foods. So an example is, if I eat that bagel, I will gain 10 pounds tomorrow. Those magical beliefs are often not necessarily responsive to logic or math. Part of sort of the anxiety and even the paranoia around food that can develop. There's often avoidance or rituals surrounding body weight and shape, and an overvaluation of shape or weight. And so shape and weight can become more important to someone's self-image than any other key role or trait. And that's really a hallmark of some of the cognitive components that we see in eating disorders, that people start to spend less time valuing their relationships or their work or their family or their favorite activities, and start to prioritize eating shape and weight as most important to their sense of self, which then makes changes around eating shape and weight really scary. Okay, so that's a big picture overview of the cognitive components of eating disorders. There also is a layer with eating disorders that needs to be part of treatment, which is understanding some of the medical concerns with eating disorders. Does not mean that they cannot be treated safely outpatient or in all different settings, but knowing what these medical concerns are can really help triage and get people to the right level of care. So there are very serious complications of eating disorders affecting every organ system in the body. And those complications are often related to malnutrition, but also can be related to behaviors. So some examples of those complications include dizziness or syncope. That's related to cardiac effects of malnutrition. Perimylosis or dental erosion and cavities can happen in eating disorders. That's often linked to vomiting behavior. Heart palpitations, cardiac arrhythmia, bradycardia, hypotension, and edema, more cardiac complications that can signal that the heart is under severe stress from malnutrition, or that there are adaptations in the body that have happened due to malnutrition that signal that the body's not getting enough fuel. Folks also have GI complications, so bloating, nausea, GERD, constipation. And those GI symptoms are pretty prevalent across the board. Also, complications related to malnutrition. Folks can also experience, if they're menstruating folks, they might experience amenorrhea, so a cessation of menstrual cycle. Bone fractures and osteoporosis. Right? So when the body is not getting enough nutrition, the body looks for nutrients wherever it can get them. Sometimes it's from heart tissue or lung tissue or brain tissue, and sometimes it's from the bones, right? And so the body will do everything it can to survive starvation by gathering resources where it can. And that can often mean taking calcium from our bones, which unfortunately for a lot of people is not reversible. So, with renutrition, folks can regain cardiac function. They can regain, brain tissue. We can see changes in brain volume after treatment, but we don't always see that when it comes to bones, which sets people up for osteoporosis and really severe, bone-related problems across their life if they've experienced malnutrition. Of course, so when folks don't have enough nutrition, there's also neurological effects. So folks can have really poor concentration, insomnia, even seizures. And then, signs of malnutrition that we see for anyone. So hair loss, lanugo growth. So lanugo is something that helps in temperature regulation. It's a really fine hair that grows in people whose bodies are sort of shutting down, the temperature sort of lowers at their basal rate, and so they grow this lanugo to help with temperature regulation. And folks with malnutrition can have really poor wound healing, making it really hard for them to get appropriate surgical care if they need it. These medical complications, importantly, can happen at any body size with any eating disorder. And so it's not just folks that are in smaller malnourished bodies that can have these complications. Folks in larger bodies that have had rapid weight loss or sustained malnutrition can also have these same problems and often present with more severe medical severity compared to folks in smaller bodies. That is often because medical and also allied health folks don't always recognize eating disorders in folks in larger bodies as fast, which means that they might not get access to care as fast or as appropriately or aggressively as folks that are in smaller bodies. Really important for us to remember about malnutrition is that it can really impair cognitive functioning. So even if people are walking and talking and appearing that they're fully able to make decisions, they could have pretty impaired cognitive functioning with sustained malnutrition. And getting people access to food as soon as possible as part of their medical treatment plan is really important to help them think more clearly, help them engage therapeutically, and prevent some of these horrifying medical complications from taking, from their quality of life and putting them in danger. Something that is very often part of the psychoeducation that we provide around this is the Minnesota starvation experiment. So this is something that the field learned about relatively recently. So in 1944, not 1994, but 44, not even 100 years ago, right? We didn't know very much about the physiology of starvation or how to refeed people. There were lots of people in Europe after the First World War who needed help after famine. And, in refeeding those folks, they saw people spontaneously die. There was, some complication with getting folks access to food after famine. And so we wanted to learn more about that. And so in 1944, they did this study where they took healthy young men who were conscientious objectors in the war and brought them to this starvation experiment to look at the physiology of what happens. And so there was sort of this idea of, will you starve so that other people will be better fed? And so they had a semi-starvation diet, which for them meant cutting down to 1,800 kcals. They lost about 25% of their body weight. And if you look at this kcalorie amount, I just want to highlight that, weight loss programs like Noom or Weight Watchers often recommend far less than this for many of their users. And so just want to articulate clearly that this is a semi-starvation diet that led to significant physical and cognitive changes in this experiment. Some of the cognitive changes that were not initially the target of the project, but sort of emerged from their research were understanding really significant difficulties concentrating under the semi-starvation diet. Folks got obsessed about food and calories. They were depressed. They were anxious. They were binge eating, right? So hoarding food and losing control over their eating. They were very fatigued and really struggled when they became refed with many of these things, which led us to think that just being semi-starved or fully starved can cause a lot of the eating disorder symptoms that we see in patients every day, and not at a really significant restriction level, right? So 1,800 kcals is a pretty, compared to other recommendations, a pretty substantial amount of food. And so really suggests that the body is intentionally creating a lot of these cognitive adaptations to encourage access to food, right? To increase the reward value of foods so that folks can remedy their experience of starvation. It's a really clever, physiological adaptation, but then also really looks like an eating disorder that is only caused by this physical restriction in calories. So that really does underscore that food intake first, right, to reverse the starvation can really help with understanding, what parts of this is physiologically driven and what can be explored through time. So that's a big picture overview of eating disorders. And I don't see any questions in the chat yet, so I'll just keep going and talk about what causes eating disorders. Um, I wish I knew. The answer is that we do not know. Typically, with eating disorders, we take a biopsychosocial approach to know that there are many biological, psychological, and social factors that can put people at risk for developing an eating disorder, but ultimately we don't have a clear solution. And regardless of where they come from, we know that the approaches to treatment that we have can help folks. We typically, would want to remedy those biological components, right? Like make sure that folks are getting food before addressing some of the psychological and social pieces because of what we know about starvation and medical risk and the ways that cognition can be impacted. This is a complicated picture, but this is what we do know, right, is that there's predisposing and precipitating factors for eating disorders and ways that the psychopathology can be maintained. So this is the cognitive behavioral model of anorexia. It often starts with a stressful thing, a stress-related trigger, where folks can lead to dieting, right? And this diet is impacted by lots of other things, right? So low self-esteem, perfectionism, need for control or evaluation of eating shape and weight, and this beginning to diet, right? Then that diet gets reinforced. It feels good in the short term, which then intensifies, and then folks struggle with the effects of low weight, might avoid difficult problems, and then sort of restrict even more, which then reduces the capacity to feel in control, and they get stuck in this cycle. This is, a complicated theoretical model, but, really does pan out when we look at lots of cases of folks that are struggling. It's the trigger that starts it. Okay, it looks like I have a question in the chat, so I'm going to see what that is. Okay, so I will get to these questions in a moment, but I'll say first. So there's a question about elevated lipids in anorexia nervosa. So elevated lipids can occur as secondary to malnutrition. It's something that seems counterintuitive, but is part of the process where the body's really using any fuel that it can, and so it can increase the blood lipids that are available. And it's part of the sort of lab profile of anorexia nervosa for some people. I'll show you a bit more about some resources around that, but I would specifically recommend the medical care standards guide from the Academy for Eating Disorders. It goes through each of the different lab values and what they mean. And there's also a really clever tool in the nutrition guide at the Academy for Eating Disorders that talks about how lipid values change during the process of refeeding. Hope that answers the question. I'll include those resources later. And the second question is about refeeding. So there's a question about refeeding syndrome and what we can do on an outpatient basis if we suspect refeeding. I will absolutely talk about that in a bit more detail, but refeeding syndrome, like with the Minnesota starvation experiment showed, right, is like pretty dangerous. And there's a part of, when folks go from really chronic malnutrition, so not eating very much at all, their bodies are in a different type of metabolic state than when they start eating again. And so if people go from very little oral or like food intake to a substantial amount, there's a process in carbohydrate metabolism that puts them at risk for electrolyte imbalance and cardiovascular events. So typically the recommendations around refeeding syndrome are to start slow with nutrition and then increase it gradually, and to really closely monitor electrolyte values because you can replete them to prevent cardiovascular events. Typically, if someone's at really high risk of refeeding syndrome, it's best for them to start eating in a hospital setting so that they have immediate access to those electrolytes. But I'll talk a bit more about that and can answer more questions later. So I'm going to talk very briefly about screening for eating disorders, try and provide with some tools for that. There are 2 validated primary care screening tools that honestly should be used everywhere. One is the scoff. It was developed in the UK, which is why they talk about 1 stone instead of pounds. But these 5 indicators are pretty good at detecting eating disorders and useful in at least getting an initial sense of whether someone might be ill. Another tool is the eating disorder screen for primary care. It's pretty good. It's less well validated. I would typically recommend the scoff for like a quick screening tool. It's also available in Spanish if that's something that comes up in your setting. When it comes to screening around like medical symptoms, this is from the Medical Care Standards Guide, so I really would recommend it. But there are some like medical things that we can really look for to see if someone might be at risk. Really, especially in kids, like any weight loss is a cause for concern. So I would, really recommend caution around any deviation from a kid's growth curve is a sign that something is not going well, especially if they're losing weight. But these signs, fainting, feeling fatigued, being weak, having, changes in cardiorespiratory things. So like low blood pressure, their heart rate getting slow, GI concerns, skin concerns, endocrine concerns, all those things that we talked about before. If you see any of those things, it's a sign of a possible malnutrition and potential eating disorder. In terms of medical screening for eating disorders, right? So here's growth curves, right? Any drop on those growth curves is a cause for concern. Malnutrition is sometimes defined as a percentage of body weight lost. And that doesn't necessarily have to be just folks that are low weight. Weight suppression is something that is also really important to look at. So even 5% weight suppression could be medically significant. So we see alterations in lab and cardiovascular values when folks are below their highest body weight, even if they're adults, right? And especially if they're kids. So weight suppression really is something that can keep eating disorders going and can be medically significant. Eating patterns, right? So the amount and the variety consumed and any compensatory behaviors that are going on is another thing to screen for. With physical exams, if folks are doing lying and standing heart rate and blood pressure, then we have a sense of whether their cardiac system can adapt to postural changes. If not, we would say that that is something that indicates cardiac stress, and then temperature can lower when folks are malnourished. There's laboratory and diagnostic testing that can also be done. That is all here in this guide to medical care. Things include like a comprehensive metabolic panel, an electrocardiogram, and then there's some other testing that can be considered. But I would really use this as a go-to resource on like medical safety and what to screen for. And then there's the question of, do we need to send this person to the hospital, right? And so we had that question about refeeding. And so these are the criteria that are set out in that medical care standard guide about when someone would need acute medical stabilization or acute psychiatric stabilization. And so if folks are experiencing any of these medical things, then I would send them to the hospital. You can definitely send them to us at Princeton. We take people ages 8 and up. And there's other centers in New Jersey and Pennsylvania. So CHOP is a really lovely program for kids, as well as Robert Wood Johnson. So these are, local nearby places where patients can be evaluated in the emergency room immediately and hopefully treated for these medical problems. We are an inpatient unit, so folks can come to our emergency room whenever they need it. But if they wanted more sustained care or they needed more sustained care, they could come to us for about a 30-day stay for medical stabilization and psychiatric stabilization. Okay, so now I'm going to shift gears a bit and talk about treatment in kids and adolescents. It's really sad to say that body image concerns start early. So I just did a talk at a school locally in Princeton for middle school and high school kids, starting as young as, I think the youngest kids were like 10, so they were like early middle school age. And they asked questions like, what is Ozempic? And then sang the Ozempic jingle, which was truly horrifying to see, not only once, but twice, right? And so body image concerns start early and it's only getting worse. These are old stats, but there's early data that 42% of first to third grade girls want to be thinner. 81% of 10-year-olds are afraid of being fat. half of teenage girls and a third of teenage boys use maladaptive weight control behaviors, right? And I think that my estimation, having been in a middle school and high school recently, is that it's definitely worse than this. And I think it's only getting worse with more social media access. If we look at the incidence data, eating disorders onset pretty early, so can start in early childhood, really peaks in adolescence for most. But we tend to know about the early onset cases that they can be more severe and more difficult to treat, but that's not always the case. It often comes with more psychiatric comorbidity. And different eating disorders have slightly different ages of onset. So anorexia tends to onset a bit earlier than bulimia and binge eating disorder, which can onset across the whole lifespan. But these are, again, old data. We don't really know. The detection is only getting a bit better through time. In terms of treatment recommendations for kids and adolescents, the good news is that there are some solid treatment options. The not so good news is that there's lots of room for more treatment development and improvement. So these are the gold standard treatments for eating disorders. So FBT stands for family-based treatment or family-based therapy. AFT is adolescent-focused therapy, so more individual treatment, and CBT is cognitive behavioral therapy. Really, for children and adolescents, the first go is trying to have the family involved as much as possible. And part of that is because eating disorders are self-eclipsing. It's the perspective that eating disorders make it hard for the kid to determine what their needs are, and that this might need to be a family medical intervention to help that kid reach their developmentally appropriate milestones around feeding themselves safely. So this really uses families, and the therapist approach there is to coach the parents to help the child feed themselves. That children lose their independence because they're not able to feed themselves with the eating disorder appropriately, and they can regain that independence over time as they fight off the eating disorder and their healthy self shines through. There are phases to this treatment, and like some core tenets to it. So one of the core tenets is to externalize the eating disorder, sort of thinking about the eating disorder like an outside invader attacking the child's health. And when the kid's ill, they don't have insight into how the disorder is interfering with their life. They don't have the capacity to stop it on their own. Parents would then take charge of refeeding their child and monitoring eating and setting limits and consequences, right, to help reinforce that appropriate eating behavior. And the food is like medicine, right? The kid has to take their medicine in order to heal. So if, knock on wood, if the kid had a really severe medical illness or had cancer and didn't want to take their chemo, parents would make sure that they did take their chemo, right? And so that wouldn't be an option. And really the idea is that the parents are stepping in to save their starving child, and that the therapist is really focusing the attention on coaching the parents to help with weight restoration and restoration of regular eating in their kid, with later stages of treatment really focusing on understanding what happened and repairing relationships if needed. So the phases include this phase 1, where parents are fully in the driver's seat. And we really, as therapists, would say, we don't know what causes eating disorders. Parents are really here to save the kid from this illness. They would eat all meals as a family. Some parents take leave, and it would need to be a high-calorie diet for refeeding. And with phase 1, we want that to be over as soon as possible, right? It's really a crisis intervention where the parents are taking charge with the hope that eventually the child would help steer and relationships are rebuilt. So the child would then be part of a partnership in returning them to physical health and gradually returning food choices to the patient, as well as exploring how the eating disorder has affected relationships. And then eventually working towards age-appropriate independence with appropriate family boundaries that are, developmentally guided. There are ways that it's a little different and adapted with kids and teens and young adults, but young adults too might need this kind of family support in order to become well. When we look at meta-analyses of FBTs versus individual treatment, I will say that we're overdue for an updated meta-analysis on this, but you can see that FBT is far superior in this meta-analysis compared to individual treatment for a kid. And if we look at follow-up, that is still the case, right? So FBT is really far superior than individual treatment for kids. This is a newer trial looking at the same approach for bulimia. And so you can see again that FBT is really outpacing CBT for targeted adolescents for eating disorders. And so we know that family therapy works for a lot of families. So it's really the first line, and it typically is 40 to 70%, depending on the study, have a good outcome. It's best when the kid is younger, when they live with the parents, when they haven't been sick for very long, and the family has high cohesion. When there's more parental criticism or high expressed emotion, there's a poorer prognosis. And so it's not a fit for all kids and all families, but it is the strongest resource that we have for kids right now. So that's the review for kids. I will breeze through our treatment for adults and then save some time for us to just have a conversation. The treatment recommendations for adults, again, it's some mixed news, so it's good that CBT is available. And there are other treatments, including interpersonal and more psychodynamic treatments that are available. There's recent work looking at values and strength-based approaches for anorexia that will be updated on this at some point. But yeah, I mean, CBT is really first line for adults, and second line includes more psychodynamic or interpersonally focused treatment, with pretty limited recommendations so far for ARFID, but the CBT work that I've seen has been pretty clever. So I would recommend again CBT as a first line approach. When we look at the data, CBT tends to do better than other treatments, and so CBT is more effective for bulimia nervosa, especially when it's therapist led. There's less solid information for anorexia, but really is showing that CBT is definitely better than just pharmacological treatments. It also significantly improves quality of life. And so this is across eating disorders, that there's improvements in quality of life, subjective and rated on a scale across eating disorders. So, really good to consider CBT in this way. CBT for eating disorders again has phases, and so it includes that first stage when we are really working on engaging in change and managing resistance, remembering that eating disorders can be self-eclipsing, really working on regular eating and refeeding, to minimize weight suppression in people of all shapes and sizes. Measuring weight at times every session is part of CBT, which can be a challenge, but it's also really important to, make weight be a goal and also something that is just one vital sign of many that can indicate, working towards better nutrition. In stage 3 and 4, there's more space when someone is cognitively and behaviorally more regulated around food and nutrition, to really work on changing dietary rules even further, challenging feared foods, challenging distorted thoughts about weight, body, and behaviors, and building up body satisfaction and self-esteem through time. This can also be the time to address interpersonal problems in life and make other big changes, as well as teaching coping and relapse prevention strategies. In terms of behavioral components, so the B in CBT, I think that the B is pretty important in the beginning, especially in combination with motivational work. And so this can mean regular eating, right? 3 meals, 3 snacks a day, same time of day, working on adherence to that pattern, really so that folks are meeting their nutritional needs, and self-monitoring when it's appropriate. Exposure exercises are also a natural part of this. So measuring weight, challenging feared foods, and talking through body image concerns. There is a pretty useful tool that's available for folks that are outpatient called Recovery Record, where you are logging things about a meal without monitoring caloric intake or carbs or things like that. It is free to use for a certain number of patients. I would recommend that everyone take a look and see, right, that it really helps with that understanding of what's happening around meals and snacks, helping with adherence to that 3 meal, 3 snack pattern, and can really show progress through time. It also has some pretty nice options for guided coping skill use, which can be very useful for folks when they're outpatient. In terms of exposure exercises, there's lots of different creative ways to do this, but feared food exposures are very common, Weight exposures are very common, and body image and shape exposures are common too, although there's different ways to do that that can be more or less helpful. So the idea is that distorted body image is a symptom, and helping patients realize misperception can be useful. And part of that can also be focusing on body function versus body form. So isn't it great that those legs can run, right, and can hold you up, and that our bodies do so much for us as sort of the reframing around body shape and size? I think that, in the original CBT and original body image manuals around this kind of work, there was a missed opportunity to really talk in depth about the way that society and culture conditions body dissatisfaction in people of all genders and all shapes and sizes. So really, working with patients to understand the sociocultural factors that are involved in body image, the way that media and marketing and, television and celebrities and all those things might, for many people, but also individually for them, impact body image and shape, is that cognitive piece after, some of the more behavioral interventions have helped folks become appropriately nourished. So that's an example of a mirror exposure, and then feared foods because the cupcake looks scary. All right, cognitive components we've talked about a little bit. So in traditional CBT, folks can do thought records or can have, those conversations around cognitive reappraisal, really looking at both distorted thoughts and core beliefs, and then building more coping skills, right? Tolerating distress, regulating emotions, etc. And you see the typical distorted thoughts that you would imagine in CBT in folks with eating disorders. This is, I imagine, familiar for many of you. So black or white thinking is very common. What it looks like in eating disorders is stuff like, this is a good food, this is a bad food, I can eat all the pizza or none of it. Emotional reasoning, so I feel fat, so I am fat, is an example of that. And that feeling fat is something that's common for folks of all shapes and sizes with eating disorders. And what we typically say is, fat's not a feeling, right? That's a descriptor. What's the feeling behind that? Can we articulate what the emotion is and help with understanding what you're really trying to express when you say that you're feeling fat? There's plenty of shoulds, right? Should be thinner, personalization, so I'm a bad person if I can't adhere to my plan, etc. And core beliefs, of course, would be underlying below that. So defectiveness or shame, emotional deprivation, inhibition, enmeshment, failure to achieve, right? Really a performance focus for a lot of folks. Really being hard on themselves around self-control and self-discipline, a lot of social isolation, and really unrelenting standards are some of the core beliefs that, are targeted through CBT through time. And so that is my big picture eating disorder 101 conversation. I'm happy to answer any questions that you all have, and I will remind everyone that came in a little late that the EEDS code is 73-axis. So feel free to hop some questions in the chat, or if you want to hop on and have a conversation. I am glad to talk about eating disorders with you. And I might be typing. I'll wait patiently. So there's a question about the app and whether I'd recommend that be therapist-directed or self-directed. So the app is called Recovery Record. So I'll put that in the chat. There's two different user interfaces. So there's a patient one and a clinician one, and they're linked. So the clinician can see what the patient is reporting, and the therapist can then provide them with feedback, comments, or prompts if they'd like to, which is really nice to have it, right there as a secure way to communicate and monitor. What other questions do we have?
Sorry to follow up really quickly on that. Would it be a therapist to the person is
Okay, so there's a question about there's eating disorder folks who use DBT. How does the treatment modality translate? So I think about the DBT model for eating disorders is like quite clever. There haven't honestly been that many clinical trials, which is unfortunate, but I've seen it be incredibly effective. Really, the way that DBT conceptualizes eating disorder care is that restriction becomes one of those dangerous behaviors that needs to be targeted, along with other dangerous behaviors like purging. Um, and so that could be part of a diary card, right? About like how much are you restricting and how do we target that using DBT skills, right? To reduce the urge to restrict. Because there's, urges there too, or the urge to binge or the urge to purge, right? And so there's natural parallels with things like self-harm or suicidal thoughts or behaviors. So I think there's a very natural synergy with a DBT model. Um, and Nicole, I would also embolden you all to like use your great DBT skills to adapt with eating disorders, right? That it's not so different than other urges. And DBT skills are powerful. They can address all kinds of behaviors. Um, okay, the next question is FBT ever used with adults? And has been shown to work as well as it does for children and adolescents. So FBT has been shown to be effective for transition age youth, so emerging adults. That's defined loosely. So it could be like anywhere from 18 to like 29, 30. And that does show like clinical effectiveness and can be really helpful. Um, I don't think it was directly compared to children and adolescents, but it is a reasonable treatment approach that has some adaptations so that there's a bit more autonomy and less of that phase one stuff. I think that, the role of supports gets more complicated when it comes to adults, right? That they are consenting to treatment. It's hard to override someone's consent or non-consent to treatment unless they're really acutely ill. And so that's a whole layer of complication when it comes to interventions with adults. I don't know if that answers the question, but Brunel, feel free to pop in if it doesn't. And then there's a question about what happens when weight measurement is triggering and necessary as part of treatment. A very good question, right? That, naturally we want our patients to do what we can to help them feel less distressed. And in this context, it's not useful to accommodate that distress so often. So for example, I think about other high acuity settings, for example, where folks might be engaging in self-harm behaviors, where they might be feeling like it's really triggering to have someone check their skin, right? Or like have a doctor check to see, where there are old or new marks. And nonetheless, that might be necessary to maintain their safety. And likewise, that can be the case for weights as well. There is like a mixed opinion about whether blind weights are okay for some people, or whether that sort of reinforces avoidance. I don't think there's a clear answer to that. Typically, at like a really high level of care, like inpatient, we would do blind weights, right? So not let people see their weights to minimize distress, to pick our battles. But when it's someone that's outpatient, it might be a matter of, saying that we need to do this to keep you safe, and that's the way it is. And then really working to provide some positive reinforcement and reward for that. So, allowing that to be something that's really praised, right? Like you were so brave in getting your weight done today. Good job, right? Or like now you get access to, like a warmer version of therapy or some other, incentive moving forward. But yeah, I mean, I think that using all of our behavioral skills around that can be really helpful. I hope that answered the question. Um, let's see. And then Ray has a question about college students. Considering the unique developmental stage and campus environment. So unique things about eating disorder treatment for college students. Eating disorders are very common in college students. Most campuses have an eating disorder treatment team that will provide medical check-ins, which I would highly recommend if any of you are treating college students to have their campus health be aware of that so that they can, provide good monitoring when parents are not available to do that. And also a really strong incentive to remain in treatment and remain well, which is, condition putting school as a condition of wellness. So I think that that becomes a powerful reward structure for fighting the eating disorder for college students. And it's sort of like a modified FBT. If the students are at college, then the school can take some of that role of parent in setting boundaries and conditions around wellness. Um, Hope that answers two. And then Megan is asking about how do you deal with body dysmorphia in the context of eating disorders? Um, I would say that, it depends on where someone is in their recovery process, um, and where the most important target of treatment is in the moment. So, like I said before, the B comes first, right? So folks have to be eating regularly and maintaining safety in their bodies before we would even start to really talk about body image. And then, that's in part because that's a time when folks have all the cognitive resources they would need to really understand what's going on and be able to fact check things with their bodies. Um, but I would, take a typical CBT approach to body dysmorphia, right? So like, how do we challenge some of the negative automatic beliefs? How do we reality test whether or not things are actually the way that they feel? And then how do we put that in social and cultural context? Sometimes body dysmorphia is just about like body size, but sometimes it's about features or other kinds of things. And so it can really, at times be a comorbid kind of condition that's more OCD-like. And in those contexts, I'd really recommend exposure and response prevention approaches to body dysmorphia. A big answer. Any other questions? Anyone want to chime in with their voice, or we have time for one more question? Sounds like I've answered every question possible about eating disorders. So thank you all for joining. Really appreciate it. And hope that you can join us next time for a conversation similar to this about substance use disorders. Have a good rest of your afternoon.